Live, and we're live. Hey, whew, I bet all of you, and that means everyone in the audience that is happy to see us again. We have been off for a while, and then it's basically because I got lost in the whirlwind that was HealthCon, even though I didn't officially go. So everyone else went, and I soaked. So anyway, HealthCon is over, and so is my existential crisis. Ooh, so yay for meds. So I thought this would be a good time to talk about similar crises that we all go through from time to time as coders. We as coders are always put in a position of being the angel on the shoulder of providers in many ways when it comes to building and coding. That's a lot of pressure, especially for new coders trying to land, secure, and keep that new job. So I asked some of the finest, trustworthy souls to talk about real-world situations to these kind of dilemmas we may see in daily working. What's the word I'm looking for? Works. Yes, daily works. So tonight we have 5 familiar panelists to discuss this topic from different backgrounds.
Outside when I'm leaving.
We have Caitlin Brack, who's a coding educator and auditor educator at Baptist. Whoa, words is hard today. Baptist Health Deaconess Madisonville. We also have Miss Keisha Wilson, who is a CCS, CPC, CPTO compliance auditor, risk adjuster, biller, auditor, healthcare consultant of her own KW Advanced Consulting LLC. We have Kimberly Jolivet Williams, CPCO, CPC, CPB, CPMA, anesthesiast, cardiologist, EMC, EMC, coding, billing, compliance analyst at Texas Health Physicians Group. Next to last, we have Letitia Cohen, who is new. I didn't mention that she was a 5 familiar face, but we all know who Letitia is. She's CPC, a proven instructor, and the business owner at Cohen's Coding and Consulting LLC. And it's also one of the chapter advisory board Region 2 representatives for the AAPC. Lastly, but not least, we have Maya Turner, who is the managing director of Turner Expert Consulting Services, and you may have seen her as co-pilot with Jed McNamara on Healthcare Inspired. Yes, I got it all right without stumbling even once. So let's start with the basic question. What are the ethical responsibilities of a coding board? Let's start off with Caitlin. Go in order.
I'm going to let somebody else start first because my brain's short circuiting. I had an early morning, so I'm going to let somebody else start the first question.
All right, let's go on to Keisha.
Ethics. Am I muted? I'm not muted. Okay. So we're following the law. Intent, right? To follow the law and I was about to say be obedient, but is my thing shutting off or no? Okay. Yeah, so we're following the law and ethics and guidelines, and it's the intent to be mindful and observe your organization's rules and regulations when it comes to everyday workflow, right? And privacy and HIPAA and data and all that wonderful stuff. So it's the intent to be mindful. Not mindful. I'm losing my words too. I know I need some water. Yeah, but it's the intent to follow guidelines, rules, and regulations.
All right, let's continue clockwise with Maya.
Okay.
Ethical responsibilities of a coder biller. What are they?
Well, I think is to uphold the truth, right? I think it's all about upholding the truth and the integrity of what is the truth when it comes to coding. Is the truth smidged when there's something incorrect? No. And I think we have an ethical standard to be assured that whatever it is that we had something to put on is correct, because there is the Yates memo, and everybody knows that the Yates memo is kind of in and out, whatever, but at the end of the day, it's all about the integrity of everyone who touches the claim and making sure that it represents the characteristics of the services provided. And if it doesn't meet, then we have more to contend with. And it follows and it should go against our ethical and moral fiber to make sure that it upholds that standard.
All right. So you briefly said the word truth. In regards to coding and building, what is the only thing we can take as truth as
What
coders?
what we can take as truth?
Yes.
I think truth is the ability to interpret correctly what is represented on paper from
And
a
that
coding
paper,
perspective.
and that paper is the
Documentation.
yes. We can only go by documentation. So if it's in writing and it's in print, that's the only thing we can judge as truth.
Absolutely.
Right? We always say it's illegal. We forget it's legal documentation.
Yeah.
Right.
And that's what attestation is. So, Letitia, do you have anything you want to add into that, or
I mean, Maya said a whole mouthful, and I was actually going to piggyback with what she said. So I don't have anything because it's all about the honesty and also when you said the medical documentation, that if something is wrong, then we need to query because
Yeah.
what's initially documented, there could be some error or miscommunication within that note as well. So
Yes, absolutely.
Kimberly, bring up the rear? What we got about the ethical responsibilities of the coder? Is there anything you want to add to this?
Yeah. Well, y'all always hear me say it's your onus, right? This is your coding professional. You're a coding professional now. So what you do, what you represent, like I call it my Kimberlyism, it's your onus, right? You have to make sure that whatever you're disseminating, whatever you're sharing, whatever you're putting out there, even if you're working in the lines of a coder, what you're coding, that's your integrity, that's your character, that's what you're building up to make sure someone can believe in you, right? And we know what we do, what we say, how we act. I always tell everyone we could say a lot with our mouth, but our actions, that's what disseminate our true character. That becomes our destiny of what we're going to put out there. So we just always want to make sure that we keep that ethical behavior. What is our accuracy? Are we confidential when we're doing things? Are we professional? What's our professionalism? Because I know if you all are like me, there are things that will take you out of it if you let them, right? They will test
Ooh.
your professionalism, and you have to make sure you keep your power and make sure you stay on top of that because that is what you're putting out there about your ethics, your work ethics, your professional ethics, just your ethics as a person, right? Let's take the work and professionalism out of it. There are some things I just want people to know is the core of Kimberly, right? My Kimberlyisms. I want you to know that that's how I am going to be. And I want to keep in mind the people that teach me how not to be, right? And keep that at the forefront. So that's my little.
Somebody passed the offering plate. We just went to church, coding church.
That's
So
funny.
let's draw the line in sand. So ethics. When we think of ethics, like the first thing comes to mind is doing what's right. So, but there's a little more to that with coding. Is there anything we should like add into that definition to make sure that we're clear and when we talk about like being ethical, that we're covering all the bases?
The first thing I'm going to say is make sure you educate yourself because how can you hold yourself to a standard that you don't even know what is the standard? So I always tell everybody, make sure, because we all, especially me in compliance, I'm throwing different hats all the time now, and they're not always my wheelhouse, right? And I have no problem with saying, this is not my wheelhouse. Let me go and investigate. Let me go learn. Let me go research. And then let me get back with you because you want to make sure you're not just flying off the cuff and telling people things because that always ends badly. There's going to be a time where something's going to come up and you didn't do your due diligence and now they're going to question whether they can trust you as a reliable source. And
Yes.
you never want to be questioned about that. So I say in addition to that, make sure you educate yourself. Always keep your education and training and your know-how up to par with all issues because we don't all know it. We don't all know everything, and
Right.
that's okay. If you think you know everything, I bet you're the person that you don't. So you want to make sure when you don't know, go and find it out. That's the wonderful thing about us here in 2024. everything mostly is at our fingertips. If you're willing to do the work, take the training, invest in yourself with the time, the energy, and maybe sometime even the monetary resources, you can get yourself up to par on almost anything.
Absolutely.
Yes.
Coding is always a ever changing involvement of because medicine is always changing, and as we take an oath as coders, as we become certified through different entities, they have their own code of ethics. Your organization has a code of ethics that you have to uphold by, and in my opinion, even and I just like Kimberlyism, the Kimberlyism that we just got. I do believe that as people, we have to hold our own ethics and even write our own ethical standards of what we choose to be at every moment. Like Kimberly said, we all have a line that we're drawn. But what is that line? How do we define that line? You know, my name is Maya Turner, and I will always uphold the ethical and moral abilities as a coder and to uphold the truth. Boom. So, what's the next person's ethical standard? What are we saying about ourselves? And I think as coders, as billers, as anyone in the medical field, we have to abide by that and have a standard in which we live by and what we work by every single day and be viable and authentic wait
Oh my God, it's contagious. Oh, what have I done?
authenticity, provide authenticity. That's the word. I'm like authenticity about how and what we do every single day.
All
So
right,
thank you for Kim for setting that tone.
everybody at home, you know what we do now. Take a drink, right?
Got my work.
All right.
Yeah,
So,
but I think I have like as a mission, I have a commitment, integrity, and like passion, commitment, integrity. Like that's in the mission because I feel like with anything you do, as we all said, there should be integrity, but especially in coding and compliance. It's not just a job, right? We're we're the bridge between the provider and billing. We're seeing a lot of stuff, and if there's something that you're seeing that's not correct, you have like you're upholding a duty, to speak about it, bring it to your leadership, talk about it, have an open conversation. There should be process and procedures that our organization has. If not, then they want to create one. Um, but it's not just a job. And sometimes you just hear then and some people like, okay, I'm just clocking in to do a 9 to 5 and I don't care what I see. But you do because there's a real implication if something happens. You were witness to it. They're going to question you like, didn't you see all these things that were happening, and then what happened? Did you just let them go? So we always have to be mindful.
Absolutely. And I know firsthand after my awful lawsuit I've been through, they constantly remind us ignorance is not an excuse. So you can say, I didn't know, but they constantly remind us you should have known. And so we can't turn the blind eye. I also say, too, my good friend and our good friend, Sanal Patel, I love her saying, right? We're painting the medical picture, we're telling that story. And so we have to make sure that when we're doing it as coders, we're abstracting that medical record to translate that information to go out to the payers. We're making sure we're telling the story accurately. I don't want my story told wrong, right? I have my own health issues, but I don't want no more than I have. And I sure don't want no more, no less, right? So, like, give me what's due me, but don't give me anything else. And so I know our patients and our providers want the same when it comes to their patients. So,
Right.
like it's just like Keisha said, we have to take it seriously, and we have to take that oath that we take as coders seriously, and make sure that accuracy is something that we're at the top of when we're doing our abstraction as well from that medical documentation.
Something that I noticed when I was at one of my previous employers is when we would have to manually enter patient charges because we had providers that would round outside of the health system. I mean, people don't realize how easily things can turn into a compliance concern when we realize, oh, this charge meant for a 40-year-old was entered in on a 4-year-old. Why are they getting smoking cessation? Like, why are they like? And I've seen it all, and I'm sure a lot of you all have too. And I think we also get into compliance concerns whenever we're being told to do something from higher ups that don't understand our position, and finding ways to, you know, this is my boundary. I'm not comfortable with what you're asking me to do, and deciding what that next move is. Because I've talked with several people in that position where they're like my morals are being compromised here because I'm being asked to do something that I know is not correct. I've brought it up to compliance. I've brought it up to I've brought it up to X, Y, and Z, and nothing's being done. And I'm at that point I'm like, get out,
Yep.
get out, and then report it to CMS, report it to somebody else. But get yeah, Farrah, I agree with you. There are times when the providers, I think everyone has. I think there are, everybody across the board can be unethical. That's not just the providers. It's not just coders. It's not just auditors. There is not. It does not.
Operations.
Yes, I don't think that. I don't think ethics escapes anyone.
Yeah.
But when I was going to school for my bachelor's, that was one of the things in the textbooks. It was always, what do you do if the provider upcodes? It's like, are you kidding me? I had nurse practitioners that were scared to death to bill a level 4 because they were told by their preceptors that they should never be billing above a level 3 because they're a nurse practitioner. And I'm like, I said, sis, you have your own panel of patients, and at least most of your patients have at least three, comorbidities. What do you mean you're not supposed to be? It's like you're doing the work. Like, what you should be billing does not reflect, you know, that doesn't. It's
Yeah.
which is why I got into provider education and started working with our local universities to create, the education for their NP and PA students. Because I said, I'm getting your students, and it's conflicting information. It's like we need to step in. We need to do better here.
Go ahead, Letitia. I think you had something you want to add.
Oh yeah, to what Caitlin was saying in regards to with the ethics, and it doesn't just stop at the coder or the biller, it's the provider. And also as us coders, when we do see the providers, because sometimes, not saying all providers, but they can intimidate the coder or biller. So that's when you have to stand firm and, sometimes bring out documentation with them or information to support what you're also stating. I had a provider, every patient that came in from new and established was always the level 5.
Mm-hmm.
Scared to say something to her, then I wasn't doing my ethical duty as stating, hey, Dr. Jane, you know, this is you're upcoding every patient. They didn't come in, you're not meeting, the MDM, the HPI, all the above, a review of systems, exams, like there's no support. You're just saying a 5 if it's new or established. And but during that time, because I took my job very seriously, and I was told like your code of ethics, and if you don't do something, then you're also held reliable as well. And I don't know about anybody else, but I need my coins. So sure that I do what I'm supposed to do, ethically. And I said something to her, then we did the chain of command and all was well with that. And then sometimes they'll come back and try to intimidate you again because it's like you told on me, but it's not like I told on you. It's like Kimberly said, we have to protect everybody, ourselves, the providers when they think that we're not, of course, the patient and their medical documentation as well. So don't be scared or feel intimidated that you can't stand up to the higher uppers and say, hey, I'm going to do my due diligence, even if you do or don't.
Yes. And always trust your instincts. A lot of times if you're looking at things and you're seeing things and you're questioning whether it's right or wrong, I don't know about you all, but my grandmother used to always say, if you have to step back and question it, should I wear this? Should I say this? Should I do this? You probably should not, right? So trust your instincts. You've taken the time to develop the steps to become this certified professional. And that don't go lightly, right? So you have good instincts. I also say too, make sure you document. I know sometimes you get in that rough situation. I've been in difficult situations where I wasn't as advanced of a coder as I am now, and I didn't always know how to go up against a manager or a physician who, was not practicing or displaying what I thought was ethical behavior. So one other lady that was my mentor told me, you document in writing, you send them an email, let them respond, and you save what I call it is your little file, right? I don't know if
CYA,
you can
the
say that on
CYA
here, right?
file.
Maya said it right. So I wasn't gonna say it, but yes,
CYA.
that's right. You
CYA.
get your files together and you keep things to make sure that you can say, okay, I tried to bring it to their attention. This is what I said. This what their response was. So if nothing else, it can show you try to do your due diligence to make sure you can mitigate that risk. And if all the things fall up in the sky, you'll be the one person that's standing there with the rain with the umbrella because you
Right.
did your due diligence. So always document and cover yourself.
I mean, even with our training, with Kim study training, we have that one with the compliance, certified compliance officer, where there is a notation that is part of the OIG that if you call CMS and there is something that they state that you asked a question about, you have to take note and date it so that it's part of your references of when and who you spoke to. So CMS also and the OIG also have methods of accountability, so that you have quote unquote the CYA cover umbrella, the CYA umbrella. That's what I like to say. That's what we're gonna call it, Kim. So that we can be assured, and that's something that they even say. So if they even say it and you don't practice it, then that's putting you at risk. We all want to be viable. We want to be a viable source. And if we cannot be a viable source by means of calling CMS when we need to, then, how serious are you taking your job? I just feel like if you have a crazy ethical standard of practice where people like, oh, she said it. Okay, well, let me make sure. That's when people will automatically be very cognizant of when you say something because they know what you uphold as a coder, as a professional, as a viable source. Oh, well, she said, oh, okay, well, I know that's truth because I know she don't say anything that she doesn't prove or anything that she can't back up. It's not about what you say, it's about what's documented and what's in black and white. Don't say
Yeah.
Maya said it. Don't, no, no, no. Here it is right here.
Mhm.
No, don't say I said it. I say it all the time. And I think that if you keep that standard and have a method of reference and not say that it's not coming from me, I am quoting what's coming from OIG, from CMS, and people will realize that your methods and accountability is truth and that you uphold that truth.
Yeah, I say authoritative resources, right? And for the sake of our talk, our CYA is cover your advice. All right, you make
I
sure
like
you
that one.
That.
cover your advice.
That ain't
Okay,
what I would say, but okay, Kim.
you you do what
Cover
you
your
have to
advice.
cover your advice. Okay, and use your authoritative
Remove the
resources.
D, the I, and the E, and put another S behind A and S.
I can't.
Right.
It's too funny. But no, that's always been me. I think I mentioned that at HealthCon too, where you want to always research. Know your guidelines. Like become one with them. Go to bed with them on your pillow. No, I'm joking. But
No,
in order
final rule. That's all I gotta say. The final rule.
yeah, in order to teach it, you need to know your guidelines. So if it's
Fluidly.
something exactly, if you're not sure about something or you know in your stomach something feels a little funny, let me go to the guideline right away. Right? This is not what we're supposed to do. We're not supposed to just code like that, right? We're supposed to go back to the guidelines and query the provider. How many times do we hear you need to query the provider? But then have that conversation. Don't go in attacking, right? You want to be able to go in and say, hey, this is the finding, this is the guidelines, this is the resource. Now we need to work together as a team because sometimes physicians feel attacked when they feel like, you're just coming at them and they did something wrong. They don't like to be told I did something wrong. So we have to approach it differently where, well, this is, this is what we found. If you need to bring benchmarking, if you need to bring guidelines. And I think it depends how you approach it, how they receive it is differently. Because
Yeah.
I've been told by physicians they wouldn't like me if I was coming with a different attitude. They would just turn me off. But my approach to the situation and how I came and let them know as a team, they were open to listen. And then when they listen, that brings about change. And once they know there's issues, because oftentimes they don't know our guidelines. So we have to educate them on what we're allowed to do as a coder and auditor, and then introduce them to our world, right? We know
Yeah.
hematology oncology is one of them, right? I know we don't want to talk about it, but oftentimes with history of versus current, you would hear them say, oh yes, once a patient has cancer, always has cancer. But we know that's not the truth. So what do?
Right.
You go to the guidelines and you show them the guidelines. So once they are not receiving any more active treatment, this is what the guidelines say, not Keisha, but the guidelines. And then open it for conversation, and then process and procedures will come in place after that.
Agreed.
And there's this one statement I want to add. I always pull back this, but like in the actual CPT under the um, under medical decision making category, they snuck this statement in there that says that the final diagnosis does not in of itself confirm complexity.
Yep.
So just the fact that they have heart failure, or just the fact that they have cancer, or just the fact that they have something that is normally life threatening, doesn't mean that it is. Like it's
Absolutely.
actual what they had to put that in writing because situations like this. So like these are the rules that you have to be aware of, and that's where we come in. There's a lot of things like we are like I want to say referee, but like we set the boundaries of what's appropriate and what's not appropriate, and we try to stay within that. And that's what the hard part is, with the ethics, what is correct, what's ethical, what's not ethical. So let's talk about what some of the ethical differences between coding and clinical, because that's where a lot of times we butt heads with our provider because our definition and their definition are two different. They clash. So, what are some of the ethical differences between coders that we should be aware of? And I'm talking about common things you would see in your daily operations.
Can you say that question one more time? Because I keep hearing a lot of weird swishy noises.
Yeah.
Am I the only one hearing it?
No, I'm hearing it too. Yeah.
Okay. So I know that the way Medicare or CMS defines a lot of things is a lot different than the way that the healthcare industry itself defines things. And there's a lot of difference. So what are some things, like some kind of ethical boundaries that we have to be aware of as coders when we're dealing with providers? Because they see things from a different perspective. They're pure clinical, we're regulatory. So like, what are some things that we should be aware of when we're talking with them? And some of the things that I always try to be mindful of is when we're educated versus coaching, or I'm not a doctor, I leap. So like, what are some things that we should kind of be mindful of when we're?
I'd say one of the biggest ones that I notice is lab values. Because typically, or like anything that has like a grading scale, like with the depression screening, because we have like a we have like a generalized scale, but especially take a patient who has diabetes. Typically they, my providers say they want a patient with an A1C between 6, nothing higher than 7, right? But for an older patient who like for an older patient, it's easier for them for their blood sugars to drop. So they're okay with a higher A1C for a more elderly patient.
Yes. Can y'all hear?
I don't know what you mean. The
Uh,
microphone.
I think what they're trying to say is if we all would mute if we're not talking, they think the back feed, because the audience is hearing the back feed as well. You hear that wish? They're saying whoever's not talking, mute your mic so we're not getting that feedback. That's a great point. Thank you so much. Go ahead, Caitlin. I didn't mean to interrupt you.
Um, but like like I said, for example, um, the the diabetes example, but sometimes like because I work a lot with Medicare wellness too, and so part of the Medicare wellness is having you do a depression screening on some of those wellnesses. Well, we may have a typical a typical scoring guide, but not every patient is the same, and so what maybe if a patient is already depressed and maybe their score is lower than what's normal, maybe it doesn't require much more intervention outside. That means maybe their treatment plan is working. But if we take it at face value of what that scoring guide is, and we're not clinical, so we can't assume a mild versus moderate, severe anything. And so I've had providers use very colorful words towards me because I can't interpret their data. I said I have common sense tells me that's high, yes, and you've been very kind to share your thought process with me on why you think things through the way that you do. But if it's not documented in black and white, think in ink. So if it's not thought out in ink on the documentation, there's not much I can do with it. My hands are tied. I have to assume that it's normal unless, again, you specify otherwise. I would always tell my providers, okay, I want you to tell me if the problem is acute or chronic, what the problem is, if what you're doing to treat it, what kind of give me a status, and then what you're going to do about it. That tells me everything I need to know. I know what the problem is. I know if it's acute or chronic. Tell me if it's mild, moderate, or severe. Tell me why you think that and what you're doing about it. That's all I need. I can support just about anything if you document it out in a way that I can support it. So that's one of my biggest ones.
Yes, and honestly, I just had to have a conversation with one of my champion physicians, and our champion physicians are physicians that take the information and disseminate to the other physicians. And so I just shared with him, we see things from a different lens. So my lens from a coding, biller, audit, compliance person is not the same lens that you see it from as a physician, doctor, nurse practitioner, PA. We can partner together to bridge the gap and try to do as close as we can to make sure we each understand each other. And I always invite them to do that. And a lot of them, most physicians want to do the right thing. I mean, you may have bad actors, like with anything, you always have bad actors. But from a genuine perspective, most of them are like, just help me understand what it is I need to do to make sure that I'm in compliance. And so I just share, I'm not a clinician. So when you're documenting these things, you have to make sure you document them so that I can at least abstract it and get the information I need to be successful in coding it. If you don't completely fulfill that thought process, then it's going to make query, or it's going to make things not be completed. And neither one of us want that, right? Because it's frustrating on both ends. It's frustrating on the coder who can't get to what they need to code the case out. And it's frustrating on the provider who feel like he's done all he needs to do, but not understanding the bridging gap that he needs to with the coder and the physician. So I think letting them know automatically that we're seeing things from two different lenses. And I had one physician tell me, well, you're telling me that I can't do this or I shouldn't do this, but to the level of medical liability from my society or whatever, that is what I need to do. And I said, I am not telling you what you can and cannot do, because again, I am not a clinician. What I'm saying is what you are doing is not giving me enough of what I need to code it out the way you would like it to be coded. That does not mean clinically you don't do what you need to as a clinician, because I cannot advise of that. I don't have that skill. So I think sometimes just explaining and partnering with them, again, showing them the authoritative regulatory guidelines that we have to adhere to. Hopefully, if you do enough of those conversations, they'll start to trust in what you're saying, and they'll start to listen, and that education that you're giving will become valuable, and they'll start to, before you know it, they'll be implementing it. because they trust what you're saying and they see the authoritative resources to support it.
I also wanted to say that, when it comes to documentation and ethical and moral fiber and communication between the physicians, I always like to teach physicians that your documentation should be understandable no matter who's reading it. If someone from off the street or someone who's a third party liability, like they're a rack auditor or someone like that, because most of them aren't clinically trained. Most of them aren't. And because they aren't, they need to understand that the dollar that they're trying to recoup is not eligible because the documentation in the record supports what was billed. And so if you communicate where there are two parties who have a conversation, whether it be on paper or face to face, there is clear, identified facts that can be abstracted, and both parties can walk away understanding each other. But if that doesn't happen, if the documentation, because literally the only type of communication that physicians have in the hospital, because they don't have time to talk to each other, is in the medical record and in the documentation. But if everybody is copy and pasting, how do we know that what they did was actually what happened? So if everybody is writing their note, like everybody who has hands on it can understand what's happening on the day to day, then you're less likely to have a communication issue, because you've explained, like nobody else has been to medical school, that they can look at that note, see that this patient is sick, what you did, how you did it, and what is the next step after they have teed off or asked for consult or what have you. So when you take that stance and you communicate with them and you have the demeanor that's not condescending and not what's the word? Accu- ac- Accusation.
Accusatory.
Yeah, thank you. We need to all be on the same Family Feud or something. But accusatory of that stance, then it becomes more beneficial rather than accusatory, and they walk away understanding you, and you've effectively communicated what your point is and why it's important.
Yeah, it goes back to those saying, right? You get more with honey than you do
Then
with
you can
vinegar.
with vinegar. That's right. I think we all went to that.
Be
I have a
sweet.
story about that. Going way back when we actually used to do consultations on every single visit. You know, that 9925 whatever nonsense we used to do. So I remember having to talk to a resident years and years and years ago. So he would do these very detailed, like data driven notes, like very like lab results are there, everything is in perfect order. But his assessment was like a list. Here's what the patient has, so, diabetes, hypertension, heart failure, and here's the meds I'm giving. These are my recommendations as a consultant. And I said, for the MDM, medical decision making, it would be helpful if we had some context of the severity, because that's one of the key drivers for our medical decision making. Because we used to work with Novitas, and we still do, but Novitas said that one of the three elements. Oh, sorry. Let me back up. Years and years ago, we used to have to count the history and the exam and the medical decision making in order to get our CPT code. All three of them have to be credited. So there was a lot of a lot of data points we had to count. Not so much now, but one of the three of those elements had to be your medical decision making was, one of the ones you had to use. You couldn't just do history and an exam. So I had to tell them, you can't just list stuff. Put some context there to help us point to whether they're high risk, they're moderate risk, or low risk.
Yeah.
And after a lot of eye blinking, looking at me, I rephrased it. So I said, okay, listen, you're a chef. Okay, so somebody comes in and they're ordering something. Just like they're putting an order in for consultation. They want your opinion, they want your expertise, and you go back and you go in the freezer and you pull out this nice 16-ounce porterhouse steak and you plate it.
I'm hungry.
And then you put it on there with some perfectly spaced out green beans and potatoes and everything was great and there's juice on
Now
it.
we're talking.
Yes, and I'm giving myself a roll in here. And then you take it out yourself and you deliver it to the customer, the person who ordered the console. And they look at it and said, nothing's cooked. It's still raw. There's nothing to it. Like, you just put it in a plate and you serve it to me. I came here because I want to see your fine cooking skills in action. You just put stuff on a plate and gave it to me and then walked away. That's not what they came here for. So they're asking for a console and they're asking for expertise. You can't say, well, the labs that I did, look at that. That's an 18.1, lab result. That's obviously severe. Anybody in their right mind knows that's severe. But what if the doctor does like, well, that's why I asked you, because I don't know what that means. That's kind of a little bit outside of my scope of practice. So I want you to tell me, instead of having me have to do interpretations that I asked you to do in the first place. And then there was still some eye blinking because he didn't really get it. Sometimes you have to spell stuff out. But then there's a point where it becomes coaching. We're not just educating, but now we're coaching. And that's one of the things that I think is a gray area that we also have to be conscious about. So let's talk about coaching. What is the problem with coaching versus educating? And I think a lot of us have seen that.
Well, I guess I don't mind the term coaching in as much as leading is what I struggle with. You should not be leading a physician, and leading to me is trying to tell them what to do and how to do the things that they're trying to do. You never want to lead a physician. You in educating, you are to give them options of what they're looking at and let them go from there based on the acuity of that patient and their medical documentation. They're the clinicians. Like, I don't need to tell you how to do that job. You're the one that went to school to do that job. So I think whenever we're doing things, you want to be sure you're not leading. Leading to me is printing the LCD, right? And saying, here are the diagnoses on the LCD. Why don't you just pick one of these so we can file the claim and get it paid? You don't want to do that, right? That is not what you do. Now, if you want to say CMS has certain criteria based on their local coverage determination that they will allow this type of procedure to be performed, then they can, see, does this patient meet that criteria? There's a difference. So you have to know enough to know that you never want to lead a physician to select or pick or treat or do anything. Again, they have the knowledge. That's their expertise, not ours. So that's my Kimberlyism on that.
So I actually was talking to an OBGYN physician probably a couple of years ago, and she was talking about the ways that her coders would send her in baskets. And with some of the the OB codes, the last character is tells what trimester. And the coders were so afraid to look like they were leading that they wouldn't give her the full code descriptor to tell them what they needed. And so I said, okay, as coders, we have to be super careful in the way that we word things. I said, but that's informational. And I said, if you run into that, I said, let me know. I will send you the codes. I said, but you really need to talk to the manager of the coders. That way they know that they can give you the full code descriptors. Like if I'm talking to a provider, we got into a conversation with one of my old docs about the difference between a biopsy and a full excision. And because he was using a punch biopsy tool to do a full excision. And so I was getting confused on I was like, are you doing because you're saying a punch biopsy, but you're telling me you're doing a full excision. And so it's, sorry, my ADHD, I'm seeing the comments. I probably should have not looked, but it's squirrel. but I said, okay, I was like, I need you to talk me through what exactly are you doing? And I got to, I got copies of the lay terms of each code descriptor. I was like, okay, this is my understanding of what these codes are. Help me understand what you're doing. You'll help me look at these things. I don't think that that's a bad idea either, because when they see at what our understanding is of a procedure, it also helps them, like, okay, when I say this is exactly what this means. This is, this is medical terms on how we say what this is. And, and so it's kind of, I guess that's where, again, some of the compliance and ethics pieces come in. Is it's like, okay, I can't assume because you tell me this is how it's worded, but I think that's also treading a fine line. And I think I see one of you guys getting ready to hop onto that next piece.
No, I was looking at the comments also. So Carrie has me laughing at a few things. I think before she said something really good. Hold on, I just want to go back. She said, no, it's attract more physicians with money than you do with accusations. I thought that was a good one. And then she was talking about just now with the margins and the death and the squirrel. Yeah, so I think those are good. Yes, yeah. She got a lot of good comments there. A lot of people do, but it's always, especially if your organization has a CDI, a clinical documentation integrity or improvement department. Sometimes you would hear this conversation come up often, and it depends on if they're in risk adjustment or if they're just focusing on provider documentation. They have different ways, like they may in basket them and go through a chart and say, hey, you missed something, or we looked at the labs. But it's always a fine line when you send them that email or inbox them that you don't want to lead, right? You don't want to say, oh, yes, I noticed, the GFR is this. Did you mean to say that the patient had this kind of stage of CKD, right? But understanding where the physicians are coming from. And I think having them understand also that you just can't give it to them, but we going back to that conversation of being clear. And I know sometimes coders, we just want to get our work done. So, hey, it's this. Do they have this, or this? Tell me what it is. But you can't do that. You have to be careful because that's when you're leading them to an answer. You want to get them to understand and explain their thought process and put it on paper. And then that's clear to us when we go ahead and try to document in the record. But a lot of organizations, depending on where you go, they train you about wording, and leading. And so I think that's important when it comes to leading versus having that conversation and education. Now, there may be opportunities. Hey, we're looking at medication. You notice they're on medication. You notice their lab values, right? We have to notice that for the role that we're in. But then you bring it to them and have an open conversation about where the documentation is lacking so that they can improve when it comes to that. But when we type it in what's missing and give the code, that we're definitely leading them to the answer. And then I know sometimes physicians don't want to take the time also. They have a lot going on. There's physician burnout, I know. They tend to just go to unspecified because it's easy. But then documentation, we know oftentimes does say it, and they need to be more specific. So what is it? Is that it's not in the system? They don't have time to look for it? So yeah, I'm going to let someone else take that.
Yeah, and I know sometimes they haven't updated those templates. I know for us, they have that pick list that's been there since 2016, right? No one's updated, no one's taken the codes off, and they're right there. They're easy for them to select. So I think that could be another contribution to them picking a non-specified code as well. We want to make sure we're updating those charge masters and those pick lists in our EHRs all the time.
Mm-hmm. Yeah, and just also just for everybody, and what you just said too, Kimberly, it just all falls back to clear communication, education, and training, not just for the providers, but for us as the coders too. So that way we always stay aware and abreast of the upcoming changes, what's going on, and then educate our providers. And it takes that if your employer isn't giving you the education that you need, then there's so much education out here, like you all said, the CMS website, paying for those courses to get that education and training and learning from others who've been in that industry or that specialty for a very long time. So it's the communication, education, and training for all individuals.
I also think that when it comes to when we audit, you got to think about us, how we were audited as coders, and then think about the physician. There's always a baseline, right? And when there's a baseline, you have to be cognizant of how you grow from that baseline once you're educated. So think about how you were as a coder when you were in production and you got it wrong. You didn't get 100%. Maybe you were at 92%. And then you were at 93%. You're like, doggone it, what am I doing wrong? But then you think about, how that translates to how the physician does. There's always a baseline. And once that baseline is established, you build from there. I always say, the baseline is where they start. Then the follow-up is they overcode. And then the other one is when they're just right. It's usually 3 times that they get it right when they're starting off as a physician. So you got to think about how you were as a coder and give them the opportunity. You have to start at a baseline and build from there, but also communicate what that position is and how they can learn, and a language that they understand that motivates them to want to change. You just can't say, you did this wrong. I don't know what you're doing. You shouldn't even be in medicine. What? No, you don't say that to me.
I thought that quite a lot. How did you finish school? But then don't say that out loud or even put it in an email.
Yeah.
So let's talk about some of the most common ethical things that we may have come across, because these are things that we've seen and, we don't even think twice about them. So the first one I have on my list is coding per documentation versus coding for reimbursement. Which of these should be taking our priority?
Documentation.
You never code for reimbursement. Never.
Ever.
Never, ever, ever. No. You're always coding based on your documentation.
I feel like you're asking to be audited if you code for reimbursement. It's like, how far can we go?
But I also have to say though too, when you're green and you don't know any better, right? You get into an organization where auditing or reviewing documentation isn't as prevalent. So you're like, wait a minute, a P2P, what's that? Oh, so you mean I'm supposed to be? Because again, it's all about culture and what you learn in school and how you were trained, right? Because if you're not trained to, again, though, just like Kimberly said, ignorance is not an excuse. But if you're part of an organization where ignorance is the culture, then you don't have an excuse. You have a reason to learn more. But if it's not part of the culture for you to learn, if it's not part of the culture for you to educate the physicians, then you're in this box and the physician is do not touch. But again, if you're a coder and you're certified, I think the rules and things like that and the culture of coders have changed, because certification is really the meat of becoming a coder and they teach you these things. But if you like old school like me, like, years, and when you think about how many years you've been around, right? And you think about the culture then, what the culture is now, and where the culture is going, we're going into AI, right? So now we have to really start to be cognizant of the rules, the regulations, and the repercussions. Oh, that's good. Rules, regulations, and repercussions. That's an alliteration.
That's a good name for a new podcast you may form.
I just say, there's your 3 R's, right?
3 R's, I was about to.
So you all are going to laugh at this. When I was going to school for coding, I took classes through community college, and my teacher couldn't get us to understand evaluation and management, so she skipped the section. And we didn't learn anything about HCPCS. I didn't know anything about P2P modifiers. Like, I learned all of this on the job. It was just by God's grace, I passed my CPC exam. It took me 3 tries, and that's why. So let's be honest, the CPC exam is very hard anyways. It's a very hard exam either way you look at it. But whenever, again, going off of that, when ignorance is but I've talked to multiple universities, and as long as someone has that degree, they don't they don't care that the person isn't certified teaching the coding classes. It was a 400 level coding, like as a 400 level college class at a university that I talked to, and the person teaching the class was not certified. She'd never coded before, and her husband was a neurologist, and they would get into coding arguments, and she would call me and be like, tell him. I'm like, and so I was
Sorry.
correcting the code, and again, we all have our niches where, like, I love family practice. That is my place. That I love family med. I can do okay with the other stuff, but it's like okay, I think we need to hold our educational institutions to a higher standard. Like, that's, if you're, I mean, people are paying thousands of dollars for these courses, and you aren't even teaching them. And they were like, well, not everyone who takes these courses wants to be coders. I was like, yeah, but you're severely shafting those who do. And the people taking these courses are also going into the medical field. They need to know it. They need to know it correctly, because no one else is going to teach them. That's your job. Your job is to help give them that understanding. If you can't do that, you shouldn't be letting just whoever has a master's degree teach this class.
Well, schools have closed because of accountability, because of the coding. And, you had Kaplan, you got some Sanford Brown. Oops, did I say their names? But I did say it. And they closed the institutions because of the liability that's associated. And as a matter of fact, some of those schools where students were getting student loans had their loans forgiven because they were getting student loans for education that they never were able to get a job for, because of the lack of education, because the lack of foundation that these coders got. So you got to think about it from an educational and institutional setting. What type of standards do they have? I mean, there's a reason why you get a HEMA accredited, and so there's a reason why you're a PMCC instructor. Wink, wink, everybody on the panel. So, there's a reason why that is, and that's a reason why you're certified to become that. So it just is so much to being in an institution and to being a teacher, and the ethics behind what you're teaching. There's a reason why you become an approved instructor. You have to take an exam. You have to take and you have to learn and put yourself in the realm of a student as an adult learner. There's certain things that you have to do, but these universities who have these programs, or these fly-by-night schools, you all have to question, well, what kind of certification did you get? How long did you take? How many times did you try? Okay, well, tell me what this is. I had somebody on a UB04, they told me that the CPT code went where the PCS code went to. I said, oh, no, 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 no. Run, Forrest, run. So it's just one of those things where you just have to be careful and what they represent, and query them on what their knowledge is. And if their knowledge isn't up to par, then you just run the other direction.
To me, I tell my students all the time, and I work for a college and I work for AAPC as an instructor, and I've even worked for some small entities here in the Dallas-Fort Worth area. And I tell the students all the time, it is your onus to fact check the course that you're going through. Do you know how many students I teach, even with AAPC, who has not taken the time to even look up the CPC curriculum that they've already paid for and they're enrolled in and taking? You have to, I get that we question the ability of some of the instructors at the colleges, but you have to do your onus with all things. You need to make sure you're dealing with an accredited college, an accredited organization. I have even chapter members that will reach out to me after they've paid thousands of dollars already with some school that no one's ever even heard of. And now they want to come to the chapter officers and say, oh, can you do me a review class and teach me coding in 8 hours in one day? It's not going to happen, right? Like anything, guys, you have to vet things out. Call AAPC, see if they're part of the PMCC curriculum. Make sure that they're an approved instructor. Make sure you go and look them up and see if they just started this business where they're, and people, when they get a bad product, they yell it to the top of their lungs. Go check them out on these Google reviews and these Yelps. You have to do your onus, and that's anywhere, whether it's a college, whether it's APC, whether it's an independent school. You have to do your onus and make sure you're getting quality education. It's no different than if you were going to get your master's in business or your bachelor's in finance or your associates in arts, right? You have to do your onus. Otherwise, you always set yourself up to get a poor quality result.
All right, so let's talk about another issue that we see a lot: unbundling services due to that magical modifier 25. What is your take on that? On the use of 25 for any given situation?
Can I
Let's
just
start
beat my
with
head against a wall?
I mean, no one should, everybody should be on top of making sure they're using modifier 25 correctly with all of the information that's in our business of healthcare arena right now, from Cigna to G2211 to, I mean, like, you have to be under a rock not to be educating yourself on that. AMA has put out a booklet, CMS have booklets. I mean, you just need to do your due diligence, right? And that's with all modifiers, because 59 and its cousins is not far behind it either. So you just have to make sure, understand how to apply modifiers. If you don't understand, educate yourself, get the training.
so.
YouTube University, Google University.
Can we talk about the magical definition of a significantly separately identifiable service and what that means? Because sometimes people don't understand what it means to be significantly separately identifiable, and that's kind of the basis for modifier 25 and modifier 59 and a couple others. But let's go to Letitia. We haven't heard from her in a while.
You all haven't done such a great job of saying what I want to say. And so I'm like, well, there's no need for me to say anything, but I'm mouthing.
Great minds think alike, Letitia.
Yeah, it's like, but I'm mouthing over here. First and foremost, too, I want to say about with modifier 25 is that if you don't understand the definition of modifier 25 or any of the modifiers, there's definitions in the back of your CPT book in the Appendix B that goes into detail on how to use your modifiers and when. I do ED coding right now, so and before that, it was family medicine. So, Caitlin, I'm there with you. So, my usage of modifier 25 is kind of real narrow. So, I can only touch on those two. But using that as, when your patient comes in and you're actually getting two different services, or the more so the provider is, what's the word? Like looking into other diagnoses, like for instance, ED, if the patient comes in and the provider sees them for their level of care anywhere from 99282 to 99285, but also they come in and having something separately done from what they came in to be seen for, the provider is also doing a surgery. So I would then append my modifier 25 to let them know this patient probably came in because in my ED, we see basically family visits because of the insurance. So usually they're coming in just for their regular medical conditions, diabetes, headaches and different things of that sort, but then yet they have another problem. Oh, I need to have a biopsy done because I think I might have skin cancer or whatever the case might be, just to get looked at, and we will append our modifier 25. So I'm more ED, into that arena, real basic. I don't know if anybody else want to tap into their specialty and how they use 25 modifier 25.
I would say, especially working in compliance for multi-specialty, or if you're over hospitals or different organizations, again, with what Caitlin and said earlier too, and Letitia just mentioned about the different specialties, sometimes you may be using modified 25 more than others, but then it goes back to what Kimberly said and Maya said about research. So sometimes we get, we're thrown in, and we have productivity and we have certain numbers to reach, but understanding your guidelines, understanding your modifiers, understanding how to use them and apply them is important. Getting familiar with EOBs, and when you're seeing denials, why did you get it denied? Reading those instructions in your CPT book before the codes is super important, because they also tell you what is included here, when you can use certain modifiers, right? So we say 25 separately and identifiable. So this is completely, you're doing extra and above certain circumstances than what you came in for. So we forget, even in, I'm going to go back and I'm going to pick on hematology again, I'm sorry. But when a patient comes in for chemotherapy that day, they're coming in for this planned procedure. It's just chemotherapy. But we know with a lot of the CPT codes in the book, there's already some exam component to those procedures. So you're not billing an E&M on that visit. You're going to check your patient out if they're coming in for chemo before you administer it. Now, if you're billing an E&M on that day, what separately and identifiable are you doing besides the routine exam that goes along, that's bundled and included in this chemo to bill it separately? So maybe the patient is now complaining of new signs and symptoms. So you have to go now do a history, an exam, or medical decision making on them. And there's some process why you're billing this exam. So sometimes we forget that and we're like, oh, okay, yeah, they're just doing something simple and we're just going to throw 25 on there so we're getting paid. But anytime you're throwing 25 on there, you're saying we need to get more money or we need to get paid for this also. So does your documentation support that this was totally separate and you did more work and extra work, and this is why you need to get paid? So just agreeing with everything else that was said before,
Yeah.
too.
And I always say that too. Make sure your documentation can support it. A lot of times I used to have different entities would come and they would say, well, we don't have a separate note or we don't have a whole nother sheet of documentation. It's like, you don't have to have a separate record, but you have to make sure in that documentation you can support that modifier 25. In the cardiology arena, sometimes we have to use it all the time because we have things where patients come in for one issue and in the midst of all that, something else comes up. And it's not that it's not correct. But even with the same diagnosis, sometimes the diagnosis is not different, but is the documentation there to support the significant, separate, identifiable service from whatever else was going on in that documentation. If you have it to support it, then you're good. It's just learning that you have to have that support in order to bill it. And when you're applying that modifier to the insurance companies, you're saying we have it. So make sure you know that as a coder. You're putting on there, yes, I'm putting this modifier because I am sure that we have it. So you shouldn't be appending it if you haven't validated that documentation to support it.
Yeah, it's not a cheat code. It's not something like, when you're playing a video game and you want to turn on God mode and you just want to say, pay for everything, just put it on. No, it's not how that modifier works. Same with 59. Medicare has a thing called the NCCI manual and NCCI edits, things that are paired together because they overlap to the point where they're considered kind of mutually exclusive. So
I say, John, because I think you and I've had this discussion previously. I always tell my providers that I need to see two different plans of care. I need a plan of care for the E&M. I need a plan of care for the procedure, and that's how I can substantiate both. I think because I think you and I've had that discussion a couple of different times from auditing.
And also, there are a lot of exceptions, and there's a lot of ways it can happen, but there's also a lot of ways that it doesn't happen. So, like the one example that I see quite often, a patient comes in for a vaccine. They're coming in to get vaccinated. That's what their goal is. They want to leave after you vaccinate them. End of story. Nothing else to be done. Doesn't matter if you do a full 10 organ system review. Doesn't matter if you look at their kneecap to see if it's swollen. Not what they're there for. They want the vaccine. So, like, what E&M service are you performing in addition to the vaccination? That's all they wanted. That's like you go into go back to the restaurant. You order a steak. Puts the steak, cooks it, it's great. And he throws a sweet potato on there. I didn't order a sweet potato. It's on your plate. Got to pay for it. I didn't want a sweet potato. I didn't want an evaluation. I just came in for the vaccine. Or I just came in for an injection. That's all I need. I don't have issues with my hearing. My diabetes is in check. No, don't worry about it. I came in because one specific reason. So that's where it's not significantly separately identifiable, because it doesn't matter if you do it. There's a medical need. And what does Medicare say about medical necessity? And I know this is ingrained in a lot of your head, but what does Medicare consider medical necessity? Come on, someone's got
the overarching criteria.
Yes. So if there's no medical necessity, what we should not be doing.
And they say it, you should not be billing them. If medical necessity has not been documented, it should not be billed to Medicare. It is documented in their notes, in their regs.
I see it too many times. The patient's chief complaint is one thing, and then they go home with a laundry list of things that are being treated. It's not mentioned.
I also think, I'm sorry.
Oh, go ahead.
No, I was just going to say, sometimes, you also have to think about the way the payers are now aligning with Modifier 25 and how they are now watching things. Anthem is now reviewing preventive services with E&Ms with Modifier 25. Medicare is saying, you know what, if you build G2211 with Modifier 25, we already have this separate criteria for what we consider above and beyond. So if you're saying something is complex, then why are you billing Modifier 25? You shouldn't be billing the G2211. You should be billing whatever service it is that you're addressing in addition to that service. So I think, these payers, United Healthcare, Cigna, all of them are beginning to watch it. And if you are cognizant of the payer reel, LinkedIn is probably the best place to find whatever is going on with any payer, because we gonna tell each other what's happening and we gonna download so that we know. So again, watch the reel, watch your payers. Anthem sends provider notifications, Medicaid sends provider notifications. Be cognizant of what your payer is doing in addition to. And before Cigna rescinded their stance on Modifier 25, we did a whole campaign on documenting what goes above and beyond. It doesn't always have to be the same diagnoses, but what goes above and beyond addressing that condition, what the provider is addressing that day, what is he managing with the E&M, and what procedure that goes above and beyond. A provider gives a medication for knee pain, but he says that he wants to do an injection on the other knee to make sure that everything is supported or that they can be mobile or what have you. The documentation will have an assessment and plan about the right knee, the left knee needs blah, blah, blah. You have the support for Modifier 25 because it's going to be examined or examined and assessment and plan. But if you just have 3 lines and they're coming in for an injection, regardless if they're new or not, that doesn't support a Modifier 25. So it doesn't always have to be a new diagnosis. So be mindful of your usage of modifiers, the reason behind the modifiers, and the clinical representation of what that modifier is when you use it, specifically Modifier 25.
So can we talk about the new patient thing? Because that's a very important topic. Just because they're new. So a patient comes in, they're a new patient, never seen before. And they say something like, I got a splinter in my leg, or I stepped on a nail. Can you remove it for me? Something like urgent. Okay. So the whole reason person came is because they need that nail taken out or the splinter taken out. So do you have to do an exam? They say yes. You need to do an exam. It's medically appropriate for that patient. But are you entitled to bill a new patient visit just because they're new? Because I hear, no, they're new. We had to do an exam. We're entitled to bill for it.
Well, my stance is, and this is something that we talked about at HealthCon last year. If a patient comes in and they need a procedure, the examination is inherent because you still have to validate if they still need it for the medical necessity. But just because a new patient comes in, just like if a patient comes in and they come in for fracture care because they were seen at the ED, the x-rays prove that they already have the broken whatever, and they need treatment. The orthopedist, the orthodoc has to check to make sure that this is still medically necessary, or it's not going to spontaneously heal. So you're not going to get an E&M in addition to the fracture care, because they've already proven in the ED that they have a broken leg. So you're just going to put the cast on and you're going to get the fracture care because it's inherent to whatever it is that's going on. So in my eyes, just because it's a new diagnosis doesn't always mean that you're going to get, a service in addition to the E&M. It needs to go above and beyond that, whether it be a 90-day or a 10-day. Medicare defines minor procedures as 0 and 10. And then major procedures is 90 days. But if you've already proven that it's medically necessary because they came from the ED, you don't get that if you're already treating, because you already know what you're treating. You only get that when it's you get the inherent examination, but everything else is bundled into that payment.
Can we talk about modifier 57 real quick, because you brought that up very topic? So
okay.
Can modifier 25 be used like it was a modifier 57, which for those who know modifier 57 is for the decision for surgery. Can modifier 25 be used as if it was your decision for surgery?
No, it cannot. Nope, absolutely not. Because again, you have to define the difference between minor and major procedures. 57 is for a major procedure. Now, AMA and CMS have different definitions of major procedures. It's a pain in the butt, but 57 is designed for a major procedure that is 90 days. And 25 is designed for minor procedures that are done in a physician practice and or minor procedures that are 10 days or less. So if there's a decision for a major procedure, there has to be intent, there has to be consent, and they have to be notified of everything that's related to whatever risks that are associated with the 57 versus the 25. One is done in the office, or one is minor, 0 to 10, and then the other one is 90, but both have to have consent, informed consent, and a decision to move forward.
And you would expect to see in the documentation that there was a decision that had to be made that required and warranted modifier 57, because there are even restrictions and rules about when you're supposed to use that and when the timeline is and the allotment for that. So you need to make sure your documentation supports, again, the appropriate use of applying a modifier 57. And that's where I stress, especially with new coders, if you don't understand your modifiers, just like Leticia said, go and pull out that full Appendix B in the back of your CPT coding manual, and it's Appendix A in your HCPCS coding manual. They give you a long definition of these modifiers because we want to make sure you're secure and confident before you allow them to be applied to these medical documentations, because you want to make sure what the rules are for applying them.
I also think that there's a difference between commercial versus CMS. So you have to be cognizant of the payers that you're billing these modifiers to. And so, commercial payers tend to, especially Medicare Advantage plans, you got to be really careful of all of that, because sometimes they're supposed to follow Medicare guidelines and they always don't. So you got to be really careful about that and know and have a policy on which guidelines you as a coder and your organization follow, whether it be CMS or AMA, because that's a big difference.
Yes, and always look at your payer policies, Ma. You are so correct, because you need to understand what the payer is saying that their perception and their understanding is as well, so you know what they expect. So yes, always. And from state to state, those policies can change. Just because I'm in Texas and I have Blue Cross and you're in California, New York, Chicago, it's not the same Blue Cross. The rules are different. So you have to do it state to state, plan the plan, know what your payer policies are. Absolutely.
So hope everyone's all strapped in, because this sounds like it could be a 4-hour episode today. Oh, there's a lot of material. So let's kind of streamline onto another question, another issue. And this was one that was posed by a person in the chat. And I think it's something that we should bring about. And it's from LinkedIn user. It says, what do you do when you're getting conflicting directives about coding comorbidities? For example, if diabetes mellitus and AFib are reviewed by the physician with medications listed, should they be coded since they affect the outcome of the surgery or care, or not, since the provider did not treat? So this is a good question, because there's two different models, and I don't know if anybody is a risk coder versus just a prophy coder, but there's a slight difference. So who wants to tackle this one?
So I was gonna say that's the problem. I know they were talking about it. They had a good session at HealthCon about it. The MDM versus HCC and risk adjustment. Because we know with medical decision making, we want to see the provider's thought process. We know what the AMA says, right? Just stating that a patient is following or up with another doctor does not necessarily count. We want to see that they manage the condition in some type of way. So, but we know for risk adjustment purposes, if they list the diagnosis as well as the medication, that we can use that it was addressed. So oftentimes coders could get confused if they're seeing the documentation and just like, wait, is this HCC? Can I grab it? Yeah, I'm grabbing it for HCC, but medical decision making doesn't state that. And you always hear us use the term MEET, right? How are we monitoring, evaluating, assessing, and treating a patient? But even if you use that for documentation of an E&M, it's going to support the MDM as well as the risk adjustment. So it depends on the provider's documentation and getting them to really understand. And as we all said before, getting out of their head and onto paper so that we can clearly get it. But that's the issue, the medical decision making versus HCC, and when can you grab it and when you need more to count it, versus the comorbidities on the risk chart.
I think Kimberly, you were waving your hands earlier. Did you want to add into that?
Absolutely not, because I was waving my hand to say that risk adjustment is not my forte, and I'm going to leave it up to Keisha. That's her expertise.
That because I've already called on you. No, go ahead, Letitia. What do you got?
Oh no, I was just going to say earlier when somebody mentioned about a long laundry list of diagnoses that the providers always try to add to the documentation, but have not addressed, like Keisha said, it goes back to the MDM, because in the ED, I see a lot where the providers, they addressed all these conditions, and the primary reason why the patient came in is not what they noted, and the documentation doesn't support on the medical decision-making side. But that was just my 2 cents.
Yeah. We call that coding for the medical history. When they copy the medical history and they drag it all the way down to the assessment, and there's really no context. Like, what were you actually treating the patient's history of a fracture when they were 13?
Right.
They're 87.
Right. I mean, I think the problem list coding, that's something that we see a lot in the facility setting, is that they bring down that problem list, and they think just because it's in the problem list and they mention one problem that's in the problem list that they get credit for everything. But it's the laundry list of them being in the system for years that nobody took the time to clear out. So it's all about education and validating, the difference between a problem list and the assessment and plan, and defining that for the clinician or practitioner so that they know just because it's in a problem list doesn't mean they get credit for it. You need to address what's in the assessment and plan and what you're managing that day.
Okay,
sorry. I was going to say, you want to assess the whole note, the entire note, because oftentimes in risk adjustment and as well as medical decision making, a provider can document their findings in the exam area. I see that oftentimes, and they may not put in the assessment and plan. And when you look up, you're like, oh, wait, they had it here in the exam. So we just can't necessarily skim a note like, oh, yeah, and we go down here and code it. You really got to look at everything thoroughly.
Agreed.
How about you, Kaylin? You want to weigh in on any of the risk adjustment versus medical decision making conundrums?
He's like, no family medicine.
Yeah, that's a very tricky topic because if you're part of what they call an ACO, which is like with an accountable
care organization.
Care organization. So what you're actually reimbursed by how severe your health population is, like how bad all the patients are. So you want to capture as many as you can. Treating, the medical decision making, is a factor, but like there's a whole complexity of that. So like some places like will capture every possible diagnosis if they're treating it at least once a year or twice. Is it once a year or twice a year
At
now?
least, at least, well, at
It,
least once.
at least once. So it's like they'll make during their annual wellness visit, they'll say, "Well, how's your diabetes doing? You're in a coma? Oh, I'm sorry, I did not realize." You and they and that's where they get the 1 year credit. But when they come in for a problem, it's kind of focused on the actual problem itself. They might want to like just touch up on some things, but those are like what we call incidental findings. And Medicare has rules about coding for incidental services, and that's also a very gray area. But let's go on to something that we as coders often struggle with, and that's making documentation. Making documentation assumptions based on our understanding of medicine. So we know we didn't go to med school, and that's the running joke. Providers like they went to med school, they know what they're doing. Coders, not so much. We're not allowed to. Oh, Caitlin,
I have my MD. I have my mom doctorate.
oh, okay. So she
All
has
the
an,
mom stuff.
Yeah.
All the gross, all the mom stuff. I have that MD, but not the
true MD, the one where you just had to sit for the boards.
No.
That's a
Nothing.
tricky one. So when
There should be one for moms, though.
always an MD, right?
The
Yeah.
amount of stuff we see, absolutely. If you would have told me that I would be looking at my 3-year-old the other day and being like, "No, honey, we don't lick the floor and then eat a Cheeto." Like that's Kimberly and John. You've seen pictures of Ken's too, so it's like,
Yeah.
like yeah.
I could spend hours embarrassing my daughter, but I'm not going to because she's probably right outside the door ready to murder me. So they walk out. So the issue with coders making assumptions, well, we're not allowed to. As much as the provider it would be easier on the provider person to do that. Should we? And that's another thing. Like, if it's in the lab, the lab panels come back as it's positive for MRSA, but it doesn't make it to assessment. Are we allowed to take that and run with it?
No, I think I talked about this a little bit earlier when we were talking about like lab values, and even though we have, we have like a standardized like, hey, we want this GFR is stage 3A chronic kidney disease. Ow, it's in my hand. But we can't just. Every patient is different, and what's normal for one patient is not always going to be normal for the other one. And what might be moderately severe for one patient might be better, going based off of what's normal for them. If they have a better scoring on a specific scoring guide, we can't just take that at face value. That's why we're not allowed to interpret lab data. That's why we're not allowed to interpret documentation, because if we were allowed to do that, we don't have that medical history with the patient. We're not going to go back and see what was done on this patient 2 and 3 4 visits ago. We're worried about today's documentation. What is that patient's risk today? How are they presenting today? We're not going to go back. That's not our job. I hate being one of those people like that's not my job, but I'm not. It should be, your note should be able to stand alone. I should be able to take that and support whatever diagnosis is being dropped with that. I should be able to support whatever procedures, whatever you're doing for that patient. I should have that medical necessity right there. I shouldn't have to go back. I should be able to look at the note today.
Yeah, and it's not a benefit. I know, John, you were saying, is it a benefit, or it may be beneficial to the providers? But for me, it's not a benefit, because you are the expert that went to school all those years to be the clinician, to be able to diagnose and treat this patient. That is not what I did. I went to school to be a coder, to be able to take your expertise, interpret them from your documentation, abstract them, and communicate it to the insurance payer. Our roles are totally different. I don't want to do your role. I want you to do your role and I want you to do it well. So, will I help you see what those regulatory say you need to do it well and help you along the way to get there? We'll partner and get there. Absolutely. But no, I do not want to do your role. I don't want to be the one to ever have to feel like I'm selecting a diagnosis or a medical decision making or any of that. That is not my role. That's not what I signed up for.
Yeah, and I know providers do coding, but coders don't practice medicine. That's the bottom line. If we're looking at lab panels and the lab panel comes back and they're within that range that is clinically severe, it doesn't matter to me. I'm not supposed to know what that means. I expect the provider to tell me what that means, and then I can take it and run with it.
I also think that there's a difference, and I think for those who may not be aware, there's a difference in the way a physician or professional coder or pro fee coder looks at things versus an inpatient coder who looks at things. And if you're an inpatient coder, the game changes significantly because they are allowed to make the clinical assumption of certain things because the data is in the medical record versus a physician coder who looks at things from a day to day, like Caitlin stated. We look at what's happening today. Are they severe today? And you're looking at the total hospital admission, you look at the professional services from admission to discharge, but you individually credit for when the physician rounds on a day-to-day basis. Whereas an inpatient coder looks at the entire record and codes what's happening as the days progress. So you got to be really extremely careful about the position that you have and know who you're coding for. Because again, that's going to make a difference in what you can and cannot do and the rules and regulations between professional coding, pro-fee coding, and an inpatient coder.
Yeah, there is one tricky statement in the ICD-10 that says that in the inpatient setting, you're allowed to presume. If the patient upon discharge, that condition is not confirmed, we can code it as confirmed. It's not the same way with outpatient. I think it's ICD-10 section 4 says that, if you have any presumed ruled out or possible probable, we have to code signs and symptoms. So that's something that you really have to know that rule because coding for a facility, as a whole brick and mortar, place, the hospital is not going to be able to make a choice. So they're given a little more leeway because, they rely on the providers to give them the information. But if the information can't be obtained, a patient may leave AMA. A patient may, unfortunately may pass away before they can come to any definite conclusion. Then they can code it.
Yeah, and I think a hospital codes for resources, a physician codes are based professional opinions. Those are the difference between the two. A hospital is going to code whether they need that nutritionist, that bariatric bed. A physician is going to code based upon their professional opinion about how to manage that patient who needs that bariatric bed because they're morbidly obese. So you got to know the difference between the two worlds and why one is coding differently versus the other.
Mm-hmm. I think getting on committees. So I know I've been on a few on the hospital side where we're updating, templates and stuff, but we're having these conversations as compliance, as coders with physicians there. And they were confused about the professional versus the facility. And they were like, but you can look at the whole note, go back and look at the note. And it's like, no, it's what did you do today? And oftentimes when we're looking at the record, that's why we see those progress notes with those never ending diagnosis codes that are already resolved, but they're still on there because they were told to leave it on there for a DRG purpose, so, and they're confused of, hey, why do I need a chief complaint today? Because the patient has been here for days. You know why I'm seeing the patient, and it's, it's getting them to understand, no, you have to, it's what today, what's happening, but it's still going to, affect knowing the inpatient versus the outpatient and understanding the rules and the guidelines. And it goes back to my favorite new middle name, research, right? We got to look at our guidelines and we got to look at our policies and we got to understand them so that we can do so correctly. And I have something to say before, in case John was thinking about wrapping up. When we're talking about compliance and ethics, I can't help it because I keep seeing it on social media that we are taking snippings of patients' charts and posting them and asking questions, but you want to be mindful, right? Compliance and ethics. There's a reason we look at these compliance modules about privacy. I wouldn't want someone to take a picture of my record. I mean, even if you have questions as a coder, there's different ways to go about it than taking a snipping and posting it, because you may not know that there's some identifiers in there. And I keep seeing it, I see it here and there, Facebook, TikTok, and there's just, hey, can anyone help me with this? But you don't realize you're putting a lot of different. So you want to be careful when we talk about ethics. Before we ended, I just had to say that because I keep seeing it. So we want to be careful.
We could talk for hours on certain topics, but let's kind of like get to the actual how we deal with the ethical problems. I know, Caitlin, you have to go, right? All right, Caitlin, thank you for joining us.
Yeah, I have to hop off. It was so good to talk with each of you. Hopefully, we can all catch up soon.
This may be
I may have to
a conversation we have to continue in a part 2 episode because there's a lot to talk about. So let's talk about some of the the end outcomes. So what are some red flags that a coder should look for if they feel something is not 100% on the level and it's not like there's some possible ethical issues? What should they look for, and how should they kind of like deal with that? Like what's the best way to identify possible ethical concerns?
I guess you got to really. Oh, I'm sorry. Go ahead, Letitia.
Oh no, go ahead, Maya. I mean, I was going to say, well, really, like as far as in identifying, just for me, is more so. It goes back like paying attention to detail. So being aware and alert of what you see from the provider. So documentation, and goes back to the communication as well, that when if you see something in regards to you're coming across a particular doctor and you're always seeing maybe documentation is similar to other notes, or they're always charging up coding or down coding, not coding to the highest level of specificity, in that realm, your ethical duty is to communicate and educate. So I don't know if there's a chain of command. Some coders have to go through their team lead or their supervisor before they can reach out to a provider. And then some get the access to directly reach out to the provider, be if it's an internal system where you can communicate via the note in the system or to send an email. So I would say just being aware and alert and paying attention to detail, and that when you see something, say something. That's all I was going to say on that.
I think this reminds me of one that I'm sorry, HealthCon was just full of a lot of sessions. CJ Wolf did one, and he was talking about the OIG recent investigation with this organization who was a patient's coming in for like COVID testing. There's really no signs and symptoms, and they were billing high levels, like level 5s. Right. And there was some people that worked there, nurse practitioners, different people that were uncomfortable and knew something was wrong, but they were being told from a higher chain in command that this is what they have to do. And so they're reporting these high levels of E&M, and the service was not matching. So of course, someone blew a whistle, right? So we're talking about whistleblowers, and those are important when it comes to ethic as well. When you know something is wrong, maybe you went through a process and no one's listening and you still know something's wrong, then you have to take it higher. But I thought that was a good one because we know with the COVID, with signs and symptoms, it takes a lot to get to a level 5 if you're just coming in for a COVID swab, especially if you don't have signs and symptoms. So right there, bells and whistles should be going off when it comes to that, where we're looking at the guidelines, we're looking at the E&M grid, and we're like, wait, this is not matching up. And that goes back to research and understanding your guidelines. And then you also have that inkling in your gut, like this is not right. And it goes back to what we were saying, documentation versus payment. You're not doing this just for payment. You get paid today, but that doesn't mean you get to keep the money. And once the insurance company finds something, guess what? They're going to come back and want even more records. And this is oftentimes how it happens.
Yeah, I was going to say that a lot of times when you're dealing with those types of uncomfortable situations, an organization should have a method or a point of compliance or some sort of hotline when there's a level of uncomfortability. Um, and it should be part of every healthcare organization. The OIG mentions that. So if someone wanted to report something anonymously, there should be a method for them to do that. But again, that goes back to the culture, the availability, the bandwidth, right? And if you're going to be okay with what you're instructed to do, if that goes against your ethical and moral fiber, then you should leave. I mean, I wouldn't just say leave without no job and be like, I ain't doing that. And then, you're trying to, no, but it's about carefully thinking through what is ethically and morally part of your fiber, what you plan to do about it. And if there's no one to go to where you can report this anonymously, then you need to quietly find something and go somewhere else because it's going against everything that you were taught not to do. So if there's not a method for you to report, then it's something that you should really consider it and move forward from. You're on mute, John. We can't hear you.
I remember reading years ago that the OIG gave them guidance on this. And if you're, as a coder, are forced or compelled to break ethical standards, they gave you they gave you great advice. They said quit. They said leave your job. And I know that's hard. It's a hard answer. But they said if you're put in a position where you're going to compromise your integrity and violate possibly federal law, it's better to be out of a job than dressed in orange. So that's the hard thing, and that's the hard thing that we would have to make a decision, when to cut and run, because we do have a few bad actors out there.
Yeah, the Yates memo is a real thing, though. It's a real thing. The Yates memo is a real thing. And if anybody is not familiar with the Yates memo is a memo that says anybody who touches a claim is morally responsible. And if you're responsible for touching that claim and the outcome of something fraudulent, you're just as accountable. And if you haven't read, there have been billers that have put in the news because of what the Yates memo represented. So, it's all about your ethical and moral fiber and what you're comfortable with doing. And if you can't, and if you don't have the means to report, time to go.
Yeah. And there are you have legal backing. Like if you're adamant that you're correct and you can't do it, it's a violation of law, and you tell somebody, you notify somebody, now you're a whistleblower. They are, and I believe this is the case. Like even if you're not working for any payer, but any healthcare person that submits a claim, you're covered under the Whistleblower Protection Act. They can't demote you. They can't harass you. They can't look at you with a side eye without fear
retaliation.
Retaliation. Yeah. Any retaliation of anything, within reason. Like you can't take that as like, and now I have get out of jail free pass for anything I do. I can be late, tardy, and setting the office on fire. No, there's limits. But if you are a whistleblower, you're protected. They can't come at you and try to slander personally to drag your name through the mud or do anything to keep you from filing a claim. That's illegal. And a lot of places will try to go around that, because they don't want any claims. Like they'll kind of try to talk you down, but you still can't do it. There's no negotiating breaking the law, and that's one of the things that we have to be aware of. Like, what are the laws and why does it impact me? Yes, there was she mentioned earlier that anybody that touches the claim, you're liable. There's audit trails. It's not like it's you point the finger at every other person. They can tell who changed codes, put things in, entered it, dropped it, reported it, peeled it. It's all out there. Everything has a date and timestamp nowadays. So be careful. That's the one thing we have to address. Like we have to say, you went through schooling, you put the time in, you got certified, you did the studying. Don't throw it away because you're cutting a corner.
Mhm. Yeah, there's a reason why when we take these medical courses, you always have that first chapter, Welcome to Business and Medicine, where it talks and you go through those rules and regulations about Stark laws and anti-kickback. Sometimes people are like, why do we have to listen to this? But that's the reason why, because as soon as we touch a record, we're liable as well to what we're coding and what we're seeing. So there are implications that if you're doing it right, and then it goes to that willful and then that intent, and then you're knowing and you're ignoring it and you're seeing it. So there's a reason we teach that. I know the other day I was teaching and someone was like, why do we really have to know this? But now you're going to be a biller, right? So you're processing claims, so you have to understand. So it all goes back to understanding the laws, the rules, the regulations. Don't just listen to something because yeah, you got a job and I'm just going to skim through this. Like the stuff you're reading is important. Understanding how you can report something, as Maya said, there are chains, there are anonymous hotlines. A lot of organizations, if they have a compliance department, there is a way you can report something without other people knowing. And they will open an investigation. And guess what? That's a paper trail to what you were saying. So if there's a finding, guess what? They're going to find that paper trail. And then I know Kimberly mentioned before about emails, documentation. You want to document stuff. If you had a conversation, let them know in email because that's also a legal record and they will go back and want to see email threads.
Yeah, the cover your advice files.
Yes, yes. That's my new one. I gotta figure
Cover
out
your advice.
that tomorrow.
Yeah. So it's we've been on here in an hour and 40 minutes. I know we covered a lot of topics. We went a little more into the technical side than I typically try to, but I think this is important information because this is our livelihood and we want to protect that. We want to protect our practice. We want to protect ourselves, our providers. We want to make sure we're doing right. And sometimes it's hard to identify what's right and what's wrong. There's a lot of gray area, but talking it out. So what I want to do is I want to continue this. There's a lot of different topics of, compliance issues we didn't even talk about, such as unbundling or upcoding versus downcoding, things like that. So if you have questions that you want us to talk about a certain thing that you have, are unsure about, send them to us, and we'll talk more technical things that you should be aware of and things that are
part 3.
Yeah.
Or a repeat panel of ethically wrong things to do.
Yeah, do not list. There are a lot of podcasts out there, a lot of people that do presentations specifically for this. For example, Betty Hovey and Sanal Patel. They every Friday they do a thing called Compliance Capers, where they talk about people that got caught, people that ended up putting themselves with those nice matching bracelets because of what they did. And there's a lot of that out there. Like they probably talk every day about a different case. There's a lot of things that we could discuss, but let's hit on the main ones, and we'll reconvene again. But if you have any questions, email them to us, put them in the chat here or in the comments, and we'll try to address them next time. But we've already been here almost 2 hours. But before we go, does anybody have any questions or comments for the audience?
I feel like I'm buzzing in. I will always say, it's once you're in coding and billing and auditing and compliance, I mean, once you take this role, you should know that it's not just a job, it's a career. And so that's going to help you with how you approach it and understanding the rules and regulation, integrity. And if you're not sure about something, research. If you're still not sure, have a conversation, ask a question, but no, it's just not a regular, I'm just going to code this and whether it's right or not, that's it. It should not be like that. You have to change your mindset and understand that this is now your career. It can affect, it's a legal record. It can affect the patients. It affects everything. It's a process, right? A command, a food chain. So you want to approach it with a different mindset that what you do can impact the world, but for a different way, right? Not in a negative way. And if you're not sure, just research and have a conversation to find out, hey, this is what's going on. I'm not too sure. What do you think? And then take it from there.
I want to say that as a coder, as a biller, whatever your role is in revenue cycle, you have a voice. Remember, you have a voice and your voice matters. But if you're ever treated like your voice doesn't matter, then you need to reconsider your position and who you work for and why you're there. Your voice matters, your opinion matters, and your training matters. You're trained for a reason. You took your certification for a reason. And if you take that seriously and uphold that with the highest regard of integrity, you'll go far and your career will go far because you take it very seriously because of your training.
Well, there's nothing left for me to say because Maya, you said it very well. That is what I would have said because I actually just did an ethics like lunch and learn, and that was one of the things I said. So yeah, as a coder, just what Maya and Keisha said: be aware, and you have a voice.
And nothing that we say here should be. It's not meant to be scary or to get you off coding and scare you to the point where you hit the door running and you're not want to code anymore. But it takes a little bit of street smarts just to make sure that you're protected, and not just you, but your practice. Sometimes you have to save the practice for themselves. When it comes to weighing money versus documentation, documentation should have went out all the time. So these are things that you should really think about. Critically think about what you're doing when you're doing it, and you can never go wrong. Well, I shouldn't say that. Sometimes people make bad decisions, but for the most part, whether they're practice administrators or healthcare providers, their main intent is to do things correctly, from what they see is correct. So sometimes they might need some re-education. Sometimes they might need steering in that right direction. And that's all we try to do, just to make sure that we're pointing them in the right way. We don't ever want to point them in the wrong way intentionally, because that's never good. They actually have a word for that. But let's go ahead and finish up tonight. And again, a little under 2 hours, longest episode so far. But I hope we all learned something along this. And if you have questions, we are going to do another episode within the next few months in regards, and we'll take it a step further and maybe talk about more stuff. So thank you all for joining us, and have a good evening.
All right. Good night.
Thank you. Thank you, John.
Thank you.
Thank you so much, John. It was a pleasure.
It was awesome. You can talk all day.